Hey guys, this is Dr. Harrington, and today we're going to talk about dizziness. Now, there are two main objectives here. One is to prepare you for boards, because clearly you can't go into third year without passing your boards. And the second is to prepare you clinically for third year. Okay. It doesn't do you much good to do well on boards if you don't know anything clinically, right? So we really need to do both. So dizziness is not a particularly high yield topic for boards. So we're really going to just try to review the anatomy and the basic differential diagnosis for a dizzy patient. And this is much more important clinically, in addition to the differential diagnosis, the triggers and timing, and understanding how you do a good history for a dizzy patient, which is a bit different than some of your other patients. I want you to understand how to do a HINTS exam, because right now that's a very important, almost I'd say key exam in the dizzy patient, and learn some basics about the testing associated with the dizzy patient. And there's not much, but there's a few important things to know. Now, why is the dizzy patient important to learn about? Admittedly, this is more clinical. The dizzy G, which can be short for grandparent or Gomer, depending on whether or not you've read The House of God and how sarcastic you are. This is probably the most frustrating patient that we see in the emergency department. They're notoriously difficult to diagnose. They may have nothing. They may have a stroke. So they really span the spectrum of acuity. And there's really nothing worse than an elderly old person who's dizzy and took a fall. Because now you're worried about did they break anything as well as what caused the fall. So they're difficult patients to manage, to say the least. So to begin, let's talk about balance and some basic anatomy associated with balance. What are the things that cause imbalance, that give us a sense of balance? Will tell us about where our bodies are in space. So there are three major systems that inform our brain about where our body is in space, what's neutral, what's normal. These are vision in your eyes, your vestibular system in your ears, and your proprioceptive system, which is your arms and legs. Okay? These all filtered back into the low pons and the upper medulla, and from there those go to your cerebellum and back, as well as up into your cortex, so that you recognize where you are. Now, with dizziness in particular, the primary organ we're concerned with is the labyrinth, and particularly the semicircular canals, right? The utricle, the saccule, all right, your inner ear. All right, so we're going to focus a lot on this. In particular, when you think about the inner ear, all right, and its effect on your equilibrium, this is what we're looking at. And as we often talk about, you need to understand the relationship, particularly of the nerves to one another, and then the vascular supply to these areas. Okay, so when we look at this picture over here, you can see the anterior inferior cerebellar artery on the right side of the picture of the inner ear. And when we look at that, that is this little guy right here off the hind end of the little basilar artery man. If you look at the bottom picture, I've highlighted that for you. So that artery in particular supplies the inner ear. So what that means clinically is if you damage that, so if you have a stroke or vascular insufficiency for whatever reason, then you damage that part of the ear, and you'll get vestibular syndromes and potentially hearing loss as well, right? Because this also supplies the cochlea. When you look at the rest of the distribution of the anterior inferior cerebellar artery, you see in the dark red here on the background that it actually supplies a significant portion of the caudal area of the pons, and in the superior area of the medulla. And this includes things like your vestibular nuclei, your facial nerve nucleus, as well as your trigeminal nerve. All right, so a complete occlusion of the anterior inferior cerebellar artery is going to cause lots of brainstem findings, okay, lots of central causes of cranial nerve deficits. Now, the other part of the anatomy we need to be aware of is what runs with these peripheral nerves, right? And you can see that all these nerves run through the internal auditory meatus. so cranial nerve 8, as well as the facial nerve, cranial nerve 7. So any mass effect, something like a meningioma, is going to cause problems with 7 and 8. You'll have problems hearing, tinnitus, dizziness, as well as facial nerve deficits. And this is a peripheral nerve problem, right? So it will include both the forehead and the face. So moving on. This is a lecture about dizziness. What is vertigo? Well, vertigo is the sensation of movement when there is none, right? And I think we all should be familiar with that. It's not a terribly uncommon term in the medical world. But when people say I'm dizzy, that's not exactly what they always mean, right? So when they say dizziness, people may mean vertigo, they may mean disequilibrium, or maybe lightheadedness. So think of vertigo as spinning, disequilibrium is ataxia or imbalance, and lightheadedness is near syncope or syncope. I feel like I'm going to pass out. All right, and these included with another category which is considered other, all right, were created back over 40 years ago when a neurologist did a study that we'll talk about here in a moment. And he associated these with vestibular, cerebellar, cardiac, and psychiatric causes. So if you felt like the world was spinning, you were considered to have a vestibular cause. If you couldn't walk straight, it was considered a cerebellar cause. If you were lightheaded, it was probably your heart. And if you couldn't quite put your finger on it, then that was a psychiatric cause. This has since fallen apart. Okay. And I think here is a good reason to know where the studies came from that inform our current medical thinking. So this one came from a study in 1972 by a guy named Trockman and Hart called The Approach to the Dizzy Patient. It was published in Neurology. And the study itself was performed by a single neurologist. So we already have problems because this says there was no independent verification. One guy made all the decisions. Furthermore, he was a neurologist. So if you're not a neurologist, this doesn't necessarily apply to you. It was done in 1972, so this was before the CT scanner was available. They had skull x-rays, but clearly this is going to miss nearly all strokes. Okay, the end of this study, or the total number of patients, was 95. So in the very best scenario, he had about 24 patients in each of his 4 groups. And this is unlikely. It was probably more varied than that. And the best part about this is when testing failed to identify a specific diagnosis, the type of dizziness was used to assign the final diagnosis. What that means otherwise is if he couldn't find another answer, he just gave himself credit. So if somebody came in and they were vertiginous and he couldn't find another cause, he called it vestibular and considered himself correct. Okay, so there's some significant bias in this study, and yet this is how we pursued dizziness for the past almost half century. What we've learned since then is that all 4 categories of these are really just one thing. They're dizziness. And this is based on a study in 2007 and a subsequent study in 2008. The 2007 study demonstrated that there is no correlation between the symptoms and the ultimate diagnosis. For instance, cardiac cause. People with a cardiac cause to their dizziness often use the word vertigo to describe it. And more importantly, or as importantly, people with vertigo, it doesn't necessarily predict who has a stroke. Okay, people who have vertigo are as likely to have a stroke as people who say, I can't walk straight, who are as likely to have a stroke as people who say, I'm lightheaded. The study in 2008 found that people often use multiple descriptors. In this study, they allowed people to pick more than one descriptor. They found that people tend to use multiples. And furthermore, they asked the patients the same question a second time and found that most, at 50% in this study, changed their descriptor within 10 minutes. And usually they changed the combination of them. So where does that leave us? A general approach to the dizzy patient. Well, currently, the thinking is that we should use a mnemonic called a test. And basically, this is a common sense approach to the dizzy patient. You ask about associated symptoms, the timing and triggers of the dizziness. You have your examination signs, and then your testing. So this all makes pretty good sense. This is a fairly normal clinical exam, right? So your associated symptoms can include headache, neck pain, thinking about things like subarachnoid hemorrhage, thinking about things like carotid or vertebral artery dissection, usually vertebral artery with dizziness. Ear pain or discharge, do they have something suggestive of labyrinthitis, an inner ear infection, right, or inflammation? Chest pain or palpitations that would lead you down the syncope route, or neurological symptoms that would make you think of some central process. Your examination signs, you always check the vital signs first. I don't think this is only appropriate for the ER. I think everybody needs to look at vital signs. I think sometimes these can lead you down a path you weren't otherwise considering. Listen for a heart murmur. Is the heart rate regular? Rhythm? Do they have atrial fibrillation? What else is going on here, right? Do they have a GI bleed? Something suggestive of anemia. And then the neuroexam. And the neuroexam is really a pretty big deal here, right? Because in the absence of other symptoms to lead you down another path, you need to be checking reflexes. You need to watch them walk. Do they have an ataxic gait? You need to hear them talk. Do they have aphasia, dysphonia? You need to look in their eyes. Do they have any cranial nerve deficits? 4, 6, 3, right? So if you remember anything else, remember your neuroexam at the very least needs to be listen to them talk, watch them walk, and look in their eyes. Next, you need to establish the timing and the triggers. Okay, and what I mean by this is it constant or is it episodic? Do they have frequent attacks or infrequent attacks? Is it a waxing and waning process, or is it completely intermittent with resolution in the middle? Okay, what triggers it? Is it paroxysmal? Okay, is it triggered, or is it just spontaneous, right? Lastly, as far as a basic workup goes, you're looking at basic testing. These are all tests that can be performed in the office. They're quick, inexpensive, and easy to perform in an emergency department, okay? And what this includes is a fingerstick blood sugar, a pregnancy test, a urinalysis, and remember you can get a pregnancy and a urinalysis all on the same specimen, and an EKG. These are easy, these are quick, they give you lots of information up front, okay? So it's your very basics. These are recommended, right? Doesn't have to be on every patient, but at least you need to consider these. Now, on to some definitions of some syndromes that we're going to be evaluating. Okay, and this is, I think, a good way to classify how you approach these patients. So, acute vestibular syndrome, spontaneous episodic vestibular syndrome, triggered episodic vestibular syndrome, and chronic vestibular syndrome. And these are very straightforward. They are what they sound like. So, acute is an acute process. It happened fairly suddenly. It lasts days to weeks, but certainly no longer. Spontaneous episodic is spontaneous. Okay, there's nothing that seems to trigger it. It happens in episodes, they come and go. Triggered episodic is triggered process, comes in episodes, resolves on its own. Chronic has been going on for weeks or months. Okay, very easy, makes sense. So let's start with acute vestibular syndrome. What are the things you need to remember? First of all, let's define this, right? So acute vestibular syndrome has an abrupt onset, minutes to hours. It may be associated with imbalance, with nystagmus. They can have nausea and vomiting. They have head motion intolerance and potentially a gait disturbance. And these are some misconceptions about the evaluation of the dizzy patient, because classically we considered head motion intolerance to be a sign of something benign, like benign paroxysmal peripheral vertigo. Okay, but if you think about this, anytime you feel dizzy, if you move your head, you're going to have some kind of vestibular input, unless you bagged both sides, right? In which case you're probably dead. So you have some kind of abnormality in your vestibular input. So anytime you turn your head, okay, you're processing extra information, which is going to make you dizzy. So whether it's a benign or a malignant cause of dizziness, if you turn your head, you're probably going to feel worse. It's the same for gait disturbance. Even if whether it's a peripheral or central cause, if you're trying to walk and the world is spinning, it's going to be hard to walk. Okay, so these don't really help you. They may help tell you where this is, but this can all be associated with acute vestibular syndrome. And this lasts days to week. Any longer than a few weeks, it becomes chronic, right? And if it's short, then it tends to be spontaneous or triggered episodic. So what could this be? Well, about 75% of this are benign processes. And those are a few examples of the differential, but the big things I want you to remember are vestibular neuritis and labyrinthitis, which are really one thing. but inflammation of the inner ear. Okay? 25% of acute vestibular syndromes are due to CVAs or strokes, okay, cerebrovascular accidents. Now, there's two ways to approach these patients. You can do a worst first approach, or you can play the odds, and some of this depends on where you're at. If you're in a clinic with a well-appearing patient who has a normal neurological exam, you're probably going to play the odds. If you're working in an emergency department, some of this is how risk-averse you are. If you're very risk-averse, you're probably going to CT and admit most of these. If you're willing to take some risks, you can remember that the central causes of dizziness are rare. They're not just uncommon. I've seen 2 of these in my career, which is short at this point, but not insignificant. Okay? So I think it's important to consider the worst first, but it doesn't mean you have to work everyone up. So given that we're coming from an ER background here, we're going to start with the consideration of the worst first, which is a central cause of dizziness. And remember, a central cause of dizziness is usually accompanied with other symptoms. So they're dizzy, they're off balance, all right? And then they may have other central findings, like we talked about the anatomy earlier. There are a lot of associated nuclei here, like the nuclei for cranial nerve 7 and the nerve of the trigeminal, the nerve root, okay? The 2 syndromes that I think are worth knowing, and they'll come back in the stroke lecture later, are the lateral pontine syndrome, which is the AICA syndrome, and the lateral medullary syndrome, which is the PICA syndrome, which is also called Wallenberg syndrome. Okay? And we'll go over those here in a minute. The symptoms you really need to consider here are things like ataxia. So if you look at the top left of the screen, you can do a heel to shin test. You have a patient take their heel and run it in a straight line down the front of their leg. If it wobbles all over the place, it's a positive test, and it's a bad thing. They may have an intention tremor, particularly if they bagged some of the cerebellar projections, vestibulocerebellar tracts. Okay. Finger to nose is usually abnormal, and if you think about this as well as like heel to toe walking, which we normally do for alcoholics, are positive because, for instance, in alcohol, it's a cerebellar toxin. Okay, but these can also be positive here. You check for reflexes. In an acute process, you tend to have hyperreflexia. You listen to them talk. So we mentioned listen to them talk, watch them walk, and look in their eyes. Why is that? Well, if you listen to them talk, a lot of these patients have dysphonia because they have vocal cord paralysis. Okay, you watch them walk because they may have ataxia. They can also have dysphagia. They can't eat, once again, because they have problems, particularly if it's a Wallenberg syndrome or a lateral medullary syndrome. They can actually get their vagal nerve root or the vagal nerve nucleus. The other big thing, and really for the purpose of boards, they should have crossed findings. So ipsilateral facial findings and contralateral body findings. So weakness, paralysis, sensory changes. And then at the extreme, remember this is the brainstem. So any process here that causes edema or bleeding can cause compression of the reticular activating system, which can make you unconscious. Lastly, remember, look at their eyes. These guys can have ocular abnormalities because of the close association with particularly the abducens nucleus, so they can have a lateral rectus palsy. They can also get nystagmus. Usually you worry about bilateral or vertical nystagmus being a problem, and we'll talk about that in a minute. So we talked about all this, but to get it all in one place, the 5 Ds of central dizziness are dizziness, diplopia, or seeing double, dysarthria, or being unable to produce sounds because of vocal cord dysfunction, so they may have a froggy voice or a raspy voice, dysphagia, unable to swallow correctly, and dysmetria, okay, or dysdiadochokinesia. For a more visual interpretation of this, here's your dizziness, your diplopia, your dysarthria, dysphagia, and dysdiadochokinesia, or dysmetria. Now, I mentioned earlier we're going to talk about a couple of these syndromes, so let's start with the low syndrome, the lateral medullary, okay, which is also called Wallenberg syndrome. And remember, this is crossed findings. So as you can see over here, this poor fellow has right-sided facial symptoms, so paralysis, paresis, sensory changes, and has left-sided body changes, so weakness, paresis, right? Sensory changes. Now, as you can see on him, he's also got some right-sided changes, and this can happen depending on where the lesion is. But remember, crossed findings or bilateral findings, sometimes these guys will have bilateral leg involvement with unilateral arm involvement. And this depends on how high or low this process happens. Moving this aside, you can see the entire range of areas that are affected by this. I don't need you to learn all this in detail, but I think this does give you a pretty thorough understanding of everything that gets hit when you have a lateral medullary infarct or a PICA infarct. You can also get Horner syndrome because this affects the sympathetic system, right? And the big things that you need to remember, I think, are nystagmus, usually bilateral or vertical. You get vertigo, ataxia, hoarseness, and dysphagia, and we talked about it. These are kind of involved in the 5 Ds. All right. Clinically, and this gets us a little bit into what kind of tests you're going to do. If you suspect an infarct, so they have all these central processes, ultimately the test of choice is going to be an MRI. Now, we usually do a CT scan first, and why do you think that would be? Because we want to rule out a bleed, right? And CT scans are good for blood, okay, but they don't give you the actual brain parenchyma well. And they're not very sensitive at all for strokes, particularly posterior fossa strokes. Okay, so cerebellar strokes and brainstem strokes. Even an MRI is only probably about 80% sensitive for this, but it's much, much better than a CT scan. So as you can see here, this is a very subtle stroke. On the left is a normal appearing brainstem and cerebellum. On the right, you can see the small infarct. All right, and then on the bottom here, you can see what the anatomical view of that looks like and what's been infarcted on a kind of a more magnified level. So you can see the PICA wrapping around, and then all of the affected nuclei and tracts. All right, moving up a little bit, we're going to go over the AICA syndrome. All right, and this is a little bit more mischievous. This is, at its breadth, can include everything we just discussed with the PICA syndrome, as well as vertigo, tinnitus, and hearing loss. At the very least, it can include simply vertigo, tinnitus, and hearing loss, which sounds a lot like Meniere's disease, which we're going to talk about in a minute. So reviewing the anatomy that we saw earlier, particularly these bottom two, remember that this includes the vestibular nuclei, particularly the superior vestibular nuclei. This gets the facial nucleus as well as the facial nerve. And in the middle image there, it also gets the trigeminal. Okay, so at its most complete, it's going to get all of these, and it should be a fairly obvious syndrome. This is just a picture of the arteries as they pass around the brain, and as you can see, the AICA, it gets a little bit hazy behind there, but just to highlight it, all right, it's going to pass around the lateral pons, versus the PICA, which comes from a little bit lower and loops up the backside onto the cerebellum. Okay, so it's these three plus or minus Wallenberg syndrome. Now, those are the scary things, but what's really more likely? Well, inner ear problems are much more likely. In particular, something like right there, the semicircular canals, right? So any problem with the peripheral vestibular apparatus, so the semicircular canals, the utricle, the saccule, and this syndrome, or this complex, would be called a acute unilateral vestibulopathy, a problem with the vestibular apparatus, right? And it has to be unilateral really to get vestibular syndrome, vestibular problems. So this can be divided into vestibular neuritis, and that's dizziness alone, or labyrinthitis, or inflammation of the entire bony labyrinth, which is hearing loss and dizziness, right? Because if you get the entire labyrinth, you're including the cochlea in that, which is involved in hearing. Okay, So both of these are included in acute unilateral vestibulopathy, and these are really the things that are going to pop up on your boards. These are the things you're going to be quizzed over. Acute unilateral vestibulopathy tends to be more of an otolaryngology term. I don't know, I've heard it in primary care ever really. So when you separate these out, remember what these mean is inflammation of either the vestibular nerve and the vestibular structures, or labyrinthitis, inflammation of the entire area surrounding these. Now, initially this was thought to be secondary to viral process. You would have a viral upper respiratory infection, you would get an extension of an inner ear infection, most of which are viral, and you'd get all this inflammation around this area, which would cause you either dizziness alone or dizziness and hearing loss, and then it would resolve. Subsequent evidence would suggest that's probably not true. Ultimately, we don't seem to really know why this happens. We just know that it does. And there may be some post-viral syndrome here, but we really don't seem to be sure. The important thing is understanding it's an acute vestibulopathy, so acute vestibular syndrome. Okay, remember it's fairly sudden in onset, and this can cause, as noted before, dizziness, hearing loss. You can even get some tinnitus from this. And the most important thing of this is look at their vital signs. Are they tachycardic? Are they febrile? Do they look ill? Do they have evidence? When you look in their ear on your exam, is their tympanic membrane bulging and nasty looking? Because if they look sick, you have to worry about suppurative labyrinthitis. Now, this tends to be in older patients. It tends to be in diabetic patients or immunocompromised patients. But but a few years ago, had a fairly young, healthy girl come in who had all these things, and 12 hours later was back in the ER with fulminant bacterial meningitis. Now, she recovered, but had some deficits, including hearing loss, and this is one of the reasons hearing loss is a major consequence of meningitis. And if you look at this, you can see that on the left side of this picture, the lymphatic fluid, which is called perilymph outside of the semicircular canals, and is called endolymph inside them, but the lymphatic fluid abuts the intracranial cavity, right? So it's one thin membrane away from being meningitis if this actually gets infected. It doesn't take much to barge through there. So in these sick patients, you really need to be thinking about early meningitis. So these are the patients that you need to do a CT brain without contrast to make sure that there's no space-occupying lesion, that there's no evidence of an abscess, an intracranial abscess, and then you need to do a lumbar puncture. But once again, these are patients with vital sign abnormalities, or they've got a bad headache in conjunction with unilateral ear symptoms. All right, they don't look well. And on clinical exam, they've got findings of a bacterial infection, right? So, how do we tell the difference between these, at least to the best of our ability? Well, there's something called a HINTS exam that folks have come up with, and this includes the head impulse test, which is where the HI comes from, a review of the nystagmus. Is it unilateral or bilateral? Is the N, and then T for TS for HINTS is the test of Skew. So let's start off with the head impulse test, and this takes advantage of the vestibulo-ocular reflex, the VOR. Okay, you'll hear of this in terms of the doll's eye maneuver in comatose patients, all right, or in critically ill ICU patients. All right, this uses the same reflex arc as the oculovestibular reflex and cold caloric testing, okay? These all use the same series of pathways. And basically what you're trying to do is, as you can see at the bottom of the picture over here, you're turning the posterior lymphatic semicircular canal, and the fluid in that brushes across these little bristles in there. That plugs into the vestibular nuclei. This goes up the MLF, up into the ocular nuclei pathways, and it causes your eyes to turn in the opposite direction. Okay. Now that's kind of a quick rundown of how this works, and probably more easily understood in the doll's eye reflex. The head impulse test is basically the same thing, but now in a conscious patient. So a conscious patient walks, stumbles, or gets drug in to your ER because they're so dizzy. All right, they're able to look at you. They are conscious. They're able to move their eyes. all of their extraocular movements are intact. Okay, because clearly you couldn't do this if you can't look left because you're missing an extra, an lateral rectus over there. So everything's intact. Now I'm trying to figure out, do I think this is central dizziness or not? And remember, you're looking for a very small percentage of patients who have isolated dizziness or dizziness and hearing loss from a central cause. But this is a very important way to differentiate them. And what you do is you put your hands on their head. This is like doing OMM, like cranial OMM from the front. And you're going to whip their head to the right or the left. Now, clearly, you're going to want to clear their cervical spine first. You don't want to be breaking anybody's neck. You also need to make sure that you don't think they have like a dissection, so a ripped carotid or vertebral artery first. Okay? And what you're going to do is you're very quickly going to snap their head from side to side. And you're going to tell them to look at your nose the whole time. And sometimes this takes several attempts. The last time I did this, it took me 3 or 4 attempts until the guy realized he was supposed to look at me and look at my nose. And what you're looking for is, do their eyes stay on your nose? Okay, so kind of like what you would expect with a normal doll's eyes, somebody with an intact brainstem. Or do their eyes initially move in their head and then bounce back to your nose? So-called corrective saccades or saccades or however you want to say that. Okay, if their eyes bounce back towards your nose, so they have this kind of delayed catch-up, that's called a positive test, but what it means is it's a peripheral vestibular cause. Now, this isn't a perfect test, okay, but it's good, and it may be better than an MRI. And that's an important thing to know because it's one of the few tests that you kind of hope is positive. A positive test means a peripheral cause. So it helps, both start with P, positive, peripheral. And this is, once again, for the most part. If you think about the anatomy that's behind this, anything in this area, so the red nerves, causes this problem because it gives you altered unilateral vestibular input. That's what causes you to have a delay looking back. So this would be a unilateral phenomenon. All right. And as you notice, these synapses in the lateral pons. So if you had a very lateral pontine hemorrhage or stroke, you could still get a positive. So you get a false positive. But for the most part, positive means peripheral. It certainly means peripheral nerves. Now, and that's what that demonstrated is, remember, the AICA supplies the lateral pons. Now, these connect bilaterally. They go up into the abducens nucleus. They progress up the MLF, up the ascending fibers, and then they synapse with the trochlear nucleus and the oculomotor nucleus to give you an equal bilateral response to these in a normal patient, right? So any damage to the MLF would prevent this, but at that point, you have a comatose patient, right? Because the MLF runs right next to the reticular activating system. And we'll talk about that in the coma lecture. The other things that these do is they synapse in your vestibular nuclei and then go down into your cervical spinal cord. And that's called the vestibulospinal reflex, okay? And that processes information regarding your neck's position in space, the amount of rotation in your neck, which helps tell your body where your head is in space, right? And then down to extensor motor neurons. And the vestibulospinal reflex in particular is there to ensure that you don't extend all your muscles every time you turn your head. And if you think about a lot of the infantile reflexes, a lot of these involve body extension, in particular when you turn their head. Okay, so you have to have the vestibulospinal reflex to overcome those. All right, basic anatomy looks like this. Remember the things that come out together. All right, particularly the association between nerve 7 and 8. And a more simple example of this is right here. Okay, so you see your bundle of vestibular nuclei down at the bottom. They progress up the MLF into your 3 pairs of extraocular movement nuclei, right? And then down your lateral vestibulospinal tract and your vestibule, the descending MLF, the medial vestibulospinal tract for the vestibulospinal reflex. So complicated, simple. It's probably not so important that you understand the complicated version of this. And once again, just to try to piece together what's happening here as far as the arteries and their association, you can see the AICA wrapping around into that primary vestibular space. Okay, step 2 of the HINTS exam. nystagmus. Really all you need to know here for this is unidirectional, so one-sided, horizontal or rotary, I didn't put on here, but rolling around nystagmus tends to be associated with a peripheral cause. So look left, look right. If they look left, look right, they have nystagmus during one of those, or if you turn their head right or left and they have nystagmus one-sided, that's a peripheral cause. If they have bidirectional or vertical, that's central. Okay, tends to be associated with central causes. All right, and remember, nystagmus is just kind of a wiggling of the eye. So when I say horizontal nystagmus, they bounce back and forth left or right. When I say vertical, the eyes bounce up and down. The last test is the test of skew, and when we talk about skew, what we're talking about is skew of the eyes when you lose visual input. So much like in the Romberg, where you have a patient close their eyes and they fall down because they lose the visual input that they were using to keep their balance. What you're doing with the test of skew is removing the visual input that allows them to keep their eyes fixated. All right, and you can do this either by placing like one of your Maxwell's or a book over one of their eyes, or just covering it with your hand, or if you have one of these filtered pieces of glass, you can put this over, and this is one of those where you can see in and they can't see out so well, so they lose their visual input. And if you see their eye, like this patient on the bottom right, move, that's a positive test of skew. All right, and here again, a positive test is significant for a central cause. So if you see the eye move, it's a central cause. Now, if you don't have one of the pieces of glass, when you basically jerk down the book or the Maxwell's, if you see their eye bounce back to a neutral position, then that's also a positive test, okay? All right, so what are some mimics of a peripheral vestibulopathy? We talked earlier, if you have a very lateral pontine stroke, you may have a mimic of a peripheral vestibulopathy. All right, and that's why we do the Hintz exam. Usually in that case, you're going to have a positive test of skew. You're going to have a positive bilateral nystagmus. You're going to have something else, but there's a possibility you have a normal one. Other things you need to consider are things like metabolic derangements, drug intoxications or side effects. One of the big ones being aminoglycosides, Wernicke's encephalopathy, meningoencephalitis, which we talked about a little bit a minute ago, and then also environmental things like carbon monoxide poisoning, which usually presents with a headache in association with all this. But sometimes it's hard to get the exposure history from that. So metabolic derangements, remember sodium, hyponatremia, low sodium can cause this. Usually it takes you getting down below the 115 range before you start seeing problems like this, and it's usually associated with some abnormal behavior as well. But you can certainly get dizzy from that. You can get weak. Emoglycosides or aminoglycosides, right? So aminoglycosides, your category of antibiotic, have some significant vestibular toxicity. So these can cause an acute vestibular syndrome, but usually this comes with the history of being on something like gentamicin. Okay. The other thing that we'll see in the coma lecture and the altered mental status lecture is Wernicke's encephalopathy. So I don't know if anybody saw Fern Gully, but Batty's a pretty good example of this. And the reason he has the number 1 tie on is because this is a B1 vitamin. It's thiamine deficiency. And this is associated with encephalopathy, oculomotor dysfunction, so usually nystagmus, and ataxia, or imbalance. And some of these people will come in saying, I'm dizzy. Okay? The people who get this are easy to remember by your ABCDs. So alcoholics make up a third of these that we know of. Anorexics can have this. Bariatric surgeries can cause this because of malabsorption. You don't get the vitamins you need, so you don't get your B1. Okay, chronically malnourished, so like hyperemesis gravidarum, pregnant ladies. There was a big study out of the East that suggested this is probably more common than we think in hyperemesis. Dialysis patients, because of the loss of water-soluble vitamins in dialysis, if these aren't replaced, if they're not on vitamins. And then systemic illnesses and sepsis, because they have increased metabolic requirements. All right, so your ICU patients, if you're not replacing their vitamins, can develop a Wernicke's encephalopathy. Looking at this closer, encephalopathy can include things like disorientation, indifference, and attentiveness, and this can make them very difficult to do a good exam on and get a good history on. It can cause oculomotor dysfunction, so nystagmus. It can cause a lateral rectus palsy, and remember with lateral rectus palsy, it has the longest course of any of the extraocular nerves All right, so it is the most likely to be damaged in any systemic system. All right, so things like multiple sclerosis, any encephalopathy, any demyelinating syndrome, in fact, but hepatic encephalopathy, diabetes, this tends to be the first to have problems, and then conjugate gaze palsies, okay? And lastly, ataxia, once again, imbalance. Okay, so your patient has acute vestibular syndrome. They're HINS negative. So now this is rolling the risk dice. How risk averse are you? If you're worried, then you need to get a CT scan. If something about them feels wrong, you're primarily looking for a bleed or a stroke, right? They make it much easier if they're HINS positive. Now you are kind of dedicated to getting a CT, okay? Because something on that HINS exam was positive other than, right, the head impulse test, which you hope was positive. If it's positive, it's a peripheral cause of the head impulse test, right? But if there's something abnormal, something that does not suggest a peripheral cause, okay, so a normal head impulse test, or bilateral or vertical nystagmus, or a positive test of Skew, then you got to get a CT scan. And this was actually one of my patients on the left. She came in with diplopia and vertigo, and it had, I think, 3 falls in the past week. So this had been going on for a week. All right. Now, a CT scan has only about a 15% sensitivity for a posterior fossa stroke, but it's well into the 90% sensitivity range for bleeds, which so far is all I've really seen. On the right is a posterior fossa stroke, okay, and that's an MRI. Now, MRI is the confirmatory test with a negative CT scan, so if I see no evidence of a bleed, and I don't see a stroke, which I don't expect to, then I'm going to do an MRI looking for evidence of a stroke, so a brainstem or cerebellar stroke. Now, there's some research suggesting that the HINS exam, particularly in the first 48 hours, may be more sensitive for a central cause of dizziness than an MRI. Okay, the sensitivity may be over 95% versus an MRI, which we think is about 80% for a posterior stroke, a posterior circulation stroke, so a brainstem or a cerebellar stroke. Now, that's the best evidence we have, which is fairly weak at this point. And a lot of the studies on HINS have some bias associated with them, particularly problems with blinding. But I think it does suggest that it's probably a really good exam to know right now. And with the best evidence we have right now, it's probably the best test. If you have somebody with a positive exam here, they need to come in the hospital and be observed at the very least. Okay. So here's just some more sensitivity info on these tests. All right. Moving on. Definitions. Things are going to get a little easier and quicker here. Back to our 4 categories. We're out of acute vestibular syndrome, and that's the really scary one, right? So these should be easier. Spontaneous episodic vestibular syndrome. So this is recurrent episodes, right? Episodic. They develop rapidly and resolve in minutes to hours, occasional days, but usually minutes to hours. And there are no known triggers. And this can pretty easily be separated into benign causes, Meniere's or vestibular migraine, and serious causes, which would be really vertebrobasilar TIA, so getting ready to have a stroke. All right. Now, remember, this tends to be from thrombosis, so it tends to be stuttering. It may be gradually worsening over time, and tends to be very sudden onset with gradual resolution. So, moving on to the benign causes, Meniere's disease. Meniere's disease, or endolymphatic hydrops, basically means too much fluid in the endolymphatic fluid. Okay, it's associated with vertigo. Has to be 2 or more episodes that last at least 20 minutes. Technically, you have to have audiometric confirmation of sensorineural hearing loss, but just any complaint of hearing loss associated with that, as well as tinnitus or a sense of aural fullness, kind of is the classic description of this. All right. The important thing, I think, clinically to know about this is symptoms can wax and wane, all right? And particularly in the first 9 months, the symptoms can completely resolve between episodes. So these episodes may last minutes or hours and then go away for days to weeks before they have another episode. Hence the spontaneous episodic nature of this. So when you examine them, just like in a TIA, it may be, they may have a completely normal exam until about 9 months, plus or minus some change, when they start developing more constant symptoms. All right, so this is a review of that. 2 more episodes of rotational vertigo lasting for 20 minutes, audiometric confirmation of sensory neural hearing loss, tinnitus and or oral fullness, and remember this could be fluctuating with complete remissions in between. All right. Vestibular migraine is everything you would think of a migraine. These can be an aura, so kind of a vestibular aura before the headache, the normal classic migraine. This can actually be part of the migraine, so severe headache with dizziness. This can also happen isolated as a migraine syndrome. This can be the only symptom of a migraine. Now, these people usually have had these before. Out of a primary care office, you should always be wary of diagnosing this, okay? Because although it's thought that maybe even up to 1/3 of people will have had a migraine in their lifetime, and these are probably underdiagnosed, there are other bad things like a vertebral-basilar TIA that you really don't want to miss, especially in older patients who have never had a migraine before, right? So in somebody with a history of migraines with similar symptoms, you can go ahead and say this is probably a vestibular aspect to your migraine. The other thing I think is important to remember is patients with migraines have a higher risk of stroke. So anything different about their migraine, including if they had a history of the normal headache symptoms but now have vestibular symptoms, you need to be concerned about this representing a vertebral-basilar TIA. So what do we worry about with these? Well, they have a stuttering course, right? So which means they're often asymptomatic on evaluation. They come into your office, they come into the ER, and they look and sound fine now because everything was resolved. That's what made it a TIA. They are usually associated with other symptoms like dysarthria or diplopia. Okay, so talking funny or seeing funny. Remember that about 0.3%, maybe up to 2% of brainstem infarctions have only hearing loss and vertigo, but remember this is a brainstem infarction, so it's a rare cause of a stroke, and it's a very rare incidence within that. So overall, numerically, this is a very low incidence. The important thing that you do in these patients is evaluate them for risk factors. Do they have something like atrial fibrillation? Do they have evidence of a PE, acute coronary syndrome? Do they have valvular heart disease or CHF? Now, within this subgroup of bad strokes, things that cause brainstem symptoms, so like vertebral artery dissection, AICA infarcts, dizziness is a very common symptom. All right, so it's the second most common symptom in vertebral artery dissection behind headache and neck pain. All right, and these occur in up to almost half of AICA infarcts. But let's put this in perspective kind of graphically. So all cases of dizziness, blue. Cases of dizziness that are stroke, yellow. Cases of dizziness that are stroke that are brainstem stroke, red. Cases that present with only dizziness, hearing loss, or tinnitus, okay, is the green. So if we take those, so vertebral artery dissections, AICA strokes, now we have a really significant component, right? But if you look at all cases of dizziness, it's a very, very rare thing. This ends up as an AICA infarct. So remember what you're talking about. Remember your total N. Remember your denominator, okay? All right, back to definitions. So we're looking at all these again. We've gone over acute vestibular syndrome, labyrinthitis, and vestibular neuritis versus AICA or PICA stroke. Spontaneous episodic vestibular syndrome, which is either Meniere's or migraine, versus a TIA. Now we're going to move into triggered episodic vestibular syndrome. And really there's only one thing I want you to know here. All right, and this is benign paroxysmal positional vertigo. This tends to occur with recurrent episodes, right, that develop rapidly, just like spontaneous episodic, usually very brief, so usually less than a minute, but certainly less than 5, and they're always triggered. Okay, although the patient may not recognize that when they first present. Sometimes you have to talk through the history for them to say, oh yeah, I think it is every time I turn my head. I think it's only when I turn my head, right? This is something you have to tease out of their history. So, benign paroxysmal positional vertigo, and this is a problem, as you can see in the top, with otoliths, or little stones in the semicircular canals that migrated out of the utricle and into these canals. And they act as a dam, so the fluid doesn't flow appropriately, which gives you altered input from each of your vestibular nerves, which causes dizziness and nystagmus. Now, this should be unilateral, right? Because you should have stones only in one side. It's kind of like kidney stones. Yes, you can get them in both. No, it is not likely. Okay? And how you diagnose this is with something called the Dix Hall Pike test. Now, the Dix Hall Pike test is only appropriate to confirm your suspicion of benign paroxysmal positional vertigo. Okay? It is not appropriate in acute vestibular syndrome in which the patient has constant dizziness. It can still get worse with movement, but it is constant underlying dizziness. Okay? That is not an appropriate patient. If you have somebody with spontaneous versus triggered, and you're trying to figure out if this is truly a triggered vertigo, you do the Dix Hall Pike test. And what that means is they have no dizziness at rest. Okay? And what you're going to do is you're going to turn their head 45 degrees to one side. You're going to lay them back, and they need to be in a position where their head hangs over the back of the bed, just their head. And you lean it off the bed. They just go straight back from sitting up to lying flat with their head hanging off the back, with their head rotated 45 degrees. And you do this both sides. And if they're positive on one side, and by positive, I mean they develop dizziness, their normal symptoms, with nystagmus, unilateral nystagmus, that's a positive test, which tells you this is BPPV, and it's very specific for BPPV, assuming you did it in the right patient. Now, there's a couple things about this that have to be true. Number one, this is a delayed onset dizziness, so it doesn't happen immediately as you lay them back. It usually takes at least a couple seconds, and it can be 5 to 15 seconds after you lay them back and hang their head off for them to develop symptoms. Okay, so there's a little bit of delay into symptoms. The symptoms should resolve within a minute or two. Once again, if they don't, you have to be concerned about something else. All right, and it should be unilateral. Now, if this is true, so right patient history and a positive Dix Hall Pike, then you treat this with the Epley maneuver, which you can see here on the bottom. And you don't have to know this right now, but it's important that you start getting comfortable with it, because this is how you're going to treat these patients. You basically do the Dix Hall Pike, then you rotate their head 45 degrees to the other side, then you roll them on their side, keeping their head in the same position. Okay, rotated left 45 degrees, and then they sit back up. And sometimes you have to do this test multiple times before you really get those stones to move around and back into the utricle, and then they feel better. Oftentimes these patients have to do this a lot at home, and so you can also give them a do-it-yourself treatment for BPPV, which is called the Brant Doorhoff exercises. And this is basically what you see here. The patient rotates their head to the affected side, they lay down opposite direction, and they come straight over and lay down on the same side. They never move their head, and this helps move it along. All right, last one. We're almost done. Acute vestibular syndrome, spontaneous episodic vestibular syndrome, triggered episodic vestibular syndrome. Now we're on to chronic vestibular syndrome, right? And this is what it sounds like, last weeks to months. This is rarely emergent. Okay, regardless of where you're seeing it, this is something that may need a workup, but probably doesn't need it immediately. This is either going to be tumor, it's going to be a stroke, maybe it's going to be some other CNS lesions, and then some other things you need to worry about are things like polysensory dizziness, presbylibrium. This is basically old people. As you get older, your vestibular apparatus starts wearing out, and so you can get altered sensory input from these, and you can't compensate as well. If you're younger and you have an acute unilateral vestibulopathy, a lot of times your brain will compensate for it. And so even though you may have an active process, you overcome the dizziness. As you get older, you lose your ability to do that. Any degenerative neurologic disease, there's some psychiatric syndromes that can cause a sensation of dizziness, and this can include things like anxiety, and then drug-related. Okay, and drug-related in particular, you think about things like loop diuretics as well as NSAIDs, things like aspirin, ibuprofen, meloxicam, Aleve. All right, these are all vestibular toxins. Now, when you discontinue the drug, you can reverse the symptoms. It's not like aminoglycosides that will absolutely destroy your vestibular apparatus, but these can cause symptoms of dizziness. So it's something in a chronically dizzy patient you need to look at their drug list. Alcohol is also a vestibular toxin, okay? So quick recap. Remember, your vision, your proprioception, and vestibular apparatus all connect into your pons, primarily your pons, and your cerebellum to give you your sense of balance. All right, your AICA and your PICA are really the primary arteries that feed your vestibular nuclei and their connections. Okay, so a central cause of dizziness tends to be your AICA or your PICA. Remember your HINTS exam, right? So your head impulse test. Remember, a positive head impulse test means a peripheral cause. Bilateral nystagmus and vertical nystagmus are concerning. Unilateral nystagmus tends to suggest a peripheral cause. Okay? And a test of skew where your eye deviates is an abnormality that's consistent with a central cause, right? Because you lose your visual input, okay, which is a conscious function. And when you lose that, your central system for keeping things aligned isn't working right. Okay, remember you have acute vestibular syndrome. Okay, so things like acute vestibular neuritis or labyrinthitis, AICA or PICA stroke, spontaneous episodic vestibular syndrome, so things like Meniere's, migraine, TIAs, which are very, very rare but serious, so you need to think about them, although much more commonly you're dealing with things like Meniere's or vestibular migraine. Triggered episodic, which really BPPV, and remember, only do the Dix Hall Pike in this specific syndrome. And then chronic vestibular syndrome, which right for now don't worry about, but you're going to need, at some point you need to start learning these things and thinking about them. Remember your basic testing, fingerstick blood sugar, and pregnancy test. All right, a urinalysis, particularly in your older patients, because remember your older patients, they may have a positive urinalysis, and that may be the only thing wrong with them. They can be altered, they can be dizzy, all because of urinary tract infection. And then EKG, look for those syncopal causes. If you have a concerning history or physical, do a CT scan to rule out a bleed. If there is no bleed, they need an MRI to evaluate for ischemia. And remember, the HINTS exam may be more sensitive, particularly in the first 48 hours of symptoms, maybe more sensitive than an MRI. So a negative MRI is expected to happen in about 1 out of 5 of these cases. And they'll turn up positive 3 or 4 days later. Okay, so still be concerned even with a negative MRI if they have concerning symptoms. And lastly, remember you may have to do an LP in some of these people. You can catch some demyelinating diseases as well as meningitis if they have consistent symptoms. All right, and that is it for this. Thanks for listening. Next lecture will be on coma and decreased level of consciousness, where we're going to go over similar area of the brainstem. And then we'll get back to this in stroke as well. All right, thank you.